Go for it.
So basically, I think we have a problem here that we need to know, that the lifetime cancer risk faced by any of us is a toss of a coin, which is 50%. And that's a big thing, right? Imagine that 50% of us we're going to have cancer at one time of our lifespan, or our lifetime. And we need to work on reducing that risk. And the medical community need to recognize that risk, and we need to develop some protocols, some cocktails that we need to take it every day in order to lower that risk. And I think I was developing it with Dr. Mike Beamer, a cocktail of polyphenols, of which is curcumin, quercetin, ECGC, methylene blue, losartan. And then you, if you have anything you suggest, let's develop together a cocktail that we can take every day that would help us to reduce that chance, which is 50%. You know, I mean, that if how much people we have here? Let's say we are 15, around 15. That's mean 7 people of us will gonna have cancer for sure. And the risk of 50% can go up if you have family history, or if you have any other risk factors that may contribute to increase that. Then you will increase the chance of having cancer. So we really need to do something about it. I need all of you doctors to join together and come up with that cocktail that we can develop, which will help to lower that risk. But even if we can drop it from 50 to 40 to 30, that will be a great choice, a great thing. CBD is one thing. It does help to reduce the risk of cancer. So people who are selling the CBD, I think it's a good thing to do. Okay, so let's go with this next slide. And I don't know why. Okay, here we go. Now, also, it is very important to understand the basic of immunology. You know, in order for us to learn any kind of language, if you want to learn French or language or Italian language, then you need to learn their alphabets and their basics of their language. So the same thing in immunology. If you want to learn immunology, you need to learn the updated basics of the immunology. And immunology is changing. I mean, before we only know about Th1 and Th2, but then something came up, which is Th17 and Tregs. So there's a new informations that needs to be learned, need to be added in our curriculum in order to understand the pathophysiology of almost all chronic diseases. All chronic diseases do have some sort of immune imbalance, whether it's degenerative, autoimmune, cancer. They all have some components of immune imbalance that needs to be fixed. That's why we now start doing what we call the cytokine profile and lymphocyte mapping for all type of chronic disease. And it's not just for autoimmune or allergies, but also for cancer, for degenerative, for metabolic. It's good to have that because it could be a factor in the pathophysiology of these diseases. And understanding that the immune system, it's really regulated and controlled by what the macrophage eats. Okay, so that would determine the direction of your immune system, that determine the polarization of your immune system, that determine the subsets of your T cells, the T cell differentiation, you can say, or CBC differentiation. It's all based on what the macrophage eats. Okay, so if the macrophage eats bacteria or eats fungus, then what will happen to your lymphocytes? You will have polarizations of the immune system into Th17, right? And you will have your macrophage start producing and releasing interferon gamma and interleukin 7, and that leads to, it will secrete the tumor growth factor, transforming growth factor, and interleukin 7, interleukin 6, and that will polarize the immune system into Th17 and the Th17 starts secreting all this cytokines, interleukin-6, and that will cause a differentiation of your white blood cells into neutrophil. So if the macrophages eats bacteria or fungus, then the macrophages will start secreting all the cytokines that will differentiate your lymphocytes into Th17, and then Th17 will start secreting interleukin-17, interleukin-6, transforming growth factors, and this will lead to CBC differentiation into neutrophils. So you will see neutrophilia, right? And that's what you need in order to fight bacteria. You need neutrophils. In order to fight fungus, you need neutrophils. But of course, you don't want too much of neutrophil. You want enough of neutrophil that kills the bacteria, enough neutrophils that will kill the fungus. If you have too much of neutrophil, then you would have inflammation and you have damage. And that's why when we are treating those diseases, we are giving antibiotics or antifungal to kill the germ. But at the same time, because the immune system may be producing neutrophils and overreacting, their Th17 is overreacting and interleukin-6 is overreacting, then we need to look at something that will inhibit and lower the interleukin-6. And that's what we do in Lyme disease. So in Lyme disease, we're looking to kill the bug, but also decrease the overreaction of the Th17 by giving some anti-inflammatory. You can say ivermectin is one, low dose naltrexone is second, methylene blue. All of this will help to decrease the Th17 overreaction or overreactivity, which causes the destruction of the tissue. And also you need to give the antibiotics or antifungal that kills the bacteria and kills the fungus. Most of the antifungal, they do kill the fungus, but at the same time, they inhibit the Th17 and interleukin-6 production. So that's a good thing. So most of antifungal drugs, they do have antibiotic effect, but also they have some sort of anti-inflammatory effect by inhibiting this inflammation, which is mediated by Th17. So it's very important to know that inflammations are different. It's not just one type of inflammation. When you call inflammation, there is inflammation mainly dominated by Th17 interleukin-6. There is inflammation dominated by Th1 and cytotoxic T cells. There is inflammation mediated by Th2, and that's the allergy things. So there's different kind of inflammations. And instead of giving steroids which suppress everything, all those kind of inflammations, and put the patient at risk of having cancer and infection, it's good to really determine what kind of inflammation and come up with a drug that will inhibit specifically that kind of inflammation. I think that's better when we are managing inflammatory diseases in general. So then if the macrophages eat virally infected cells of cancer, what will happen to those macrophages? They will differentiate to M1, and then the M1 will secrete interferon and interleukin-12, and that will cause a polarization of your immune system, the naive T cells, to become what? Th1, and then Th1 starts secreting all those cytokines to stimulate the differentiation of cytotoxic T cells, the CD8, into naive CD8 to cytotoxic T cells. And that's how, you know, your Th1 responds, or it gives you that cytotoxic T cells that will go and fight those infected cells and kill those cells that's being infected with the virus by attaching to it and secreting all those cytotoxic chemicals that will open up pores into those infected cells and blow them up, right? Or they will be attacking those cytotoxic T cells. They will be attacking the cancer cells and release those cytotoxic chemicals that will blow up those cancer cells. So that's how when we want to kill cancer cells or infected cells with viruses, we need Th1 cytotoxic T cells polarizations in order to destroy the cancer. And that's how your immune system respond to the cancer pathogens or sex cells being infected with virus. Now, what about if the macrophages is eating parasites in the gut or allergies, pollens or whatever? then the macrophages will be polarizing into M2 and that's secreting all the cytokines, interleukin-4, and cause a polarization of your lymphocytes into Th2, and then you will start producing immunoglobulin E, and you will have eosinophilia and basophilia, and that's how we destroy the parasites, right? And that's how we patients manifest with allergic reactions because of interleukin-4 and how it's stimulating the mast cells release of histamines, right? And how the immunoglobulins react with those other genes and release the histamines and gives you that allergic reactions that we experience with patients, for example, with asthma or eczema. But when the macrophages eat your self-antigens, right? Then what would happen? Those macrophages, they turn into mRegs, and they start secreting interleukin-10, transforming growth factor, beta, and they will polarize the immune system to Tregs, and that will suppress the immune system, right? Will suppress all the three effectors lymphocytes with the Th1 or Th2 or Th17. So this interleukin-10 causes suppression of those effector lymphocytes, which is Th1, Th2, and Th17, and prevent your immune system from attacking your self-antigen. So that gives you what we call the immune tolerance. So now we understand that your lymphocytes differentiation, your CBC differentiation is really depend on what macrophages eat, right? And that will determine the fate of your lymphocytes, and also will determine the fate of your CBC, what direction. So if you see in your CBC lymphocytosis, then you think, oh, this could be cancer or viral infection, right? If you see in your CBC eosinophil or basophils, then you think, oh, this could be allergy or parasite infection. And then if you see your CBC neutrophil, then you think, oh, this could be fungus or this could be bacterial infection. And so the CBC differential also helps us to know exactly where your immune system is moving to, right? What about the natural killer cells? Natural killer cells really can be activated by any of those cytokines. It can be activated by interferon gamma. It can be activated by interleukin-4, by interleukin-6. So it's a general, the natural killer cells. They're not specific, and they just kill the germs or kill the cancer. It's a non-specific immune response, but it's very important. Innate immune response. So we need those natural killer cells. They are considered lymphocytes. They are considered like CD8 lymphocytes, cytotoxic T lymphocytes, but cytotoxic T lymphocytes are more specific, right? This one, natural killer cells, they are generally, they just destroy any infected cells or any or any cancer in general, regardless of what kind of cancer it is or what kind of virus it is. So it's a kind of innate immune response. Okay, so you know, the oncology, which are treating cancer, in the old school, they are focusing, those mainstream oncologists, they're focusing on just destroying the cancer. Regardless of the tumor microenvironments, at that time we have no clue about tumor microenvironment, regardless of the immune status, because those doctors of oncologists, they just throw chemotherapy, and they focusing is only to destroy that cancer, right? So those cancer cells, they have certain metabolism different from the normal cells. They target that metabolism. They develop chemicals that will inhibit that metabolic pathway in the cancer, or that will increase the free radicals and induce apoptosis in the cancer, like radiotherapy or photodynamic therapy. But that's what we do as a mainstream oncologist. We do X-ray, we do radiation, we do chemotherapy, we may do photodynamic therapy, and we may end up, if it's early and accessible, then we can just remove that cancer by surgery. That's the old school. It's funnel or tunnel kind of vision, and focusing only on how we destroy the cancer. But recently, it's not just about killing the cancer. It's also changing the tumor microenvironment and making the tumor microenvironment from favorable microenvironment to hostile microenvironments. and we call the tumor microenvironment. And that's require a lot of repurposing drugs. We're going to talk about it in the coming slides of how you can change the tumor microenvironment so it become a hostile environment of the tumor that will reject the tumor. And that's the new field of medicine, of oncology. And as integrative doctors, I think you can do better than the mainstream oncologist who is focusing only on destroying cancer by radiation and by chemotherapy and even by photodynamic therapy and by or removing the tumor by surgery. Then now recently changed the way that we manage cancer, and it involved also changing the tumor microenvironments. And we're going to discuss all the protocols that leads to change of the tumor microenvironments. So there's a change there, and we need to adapt those changes. As integrative doctors, we can do better than the mainstream oncology if we start translating all those recent protocols and publications about managing cancers and how to think outside the box, and not just thinking about killing the cancer and interfering with the metabolism of the cancer or increasing the apoptosis by using radiation or chemotherapy or photodynamic therapy or radiofrequency ablation, but also how we can change the tumor microenvironment using all those repurposing drugs that we're going to talk about. The other thing is that we need to also enhance the immune system to kill the cancer by polarizing the immune system into Th1M1. And we're going to talk about how we can polarize the immune system to Th1M1 in the coming slides. Now, it's very important to understand and know that the immune system is 24/7 checking on all the identity of your cells. And we know that that cancer emerge it's like every second you would have cancer cells emerging from your body, but your immune system will identify them and destroy them. And that kind of phase where the immune system is controlling and making some sort of immune surveillance, we called, and controlling your cells from becoming cancer and eliminating it, destroying it, like a police. When you see the police, when they see criminals, they go and they capture them and eliminate them or put them in jail. The immune system does the same thing. They are like policing, and if they find foreign cells, weird cells, they go and they destroy them. They don't really put them in jail, but they destroy them, eliminate them. And that phase we call elimination. Okay, so this is the phase of the immune surveillance. It's called what? Elimination. But it happened that the tumor cells can emerge and you can have some subclinical growth of tumor, but it's not constantly growing. It's fixed growth of tumor that in a certain way was able to evade the immune surveillance, but it's still, the immune system is able to kill those cancer cells in the number that is equal to the number of the cells that is of cancer that's emerging. So when you see that balance of the cancer cells that's growing equal to the number of cells that's dying by the immune system, this phase is called what? Equilibrium. And that's where you see a subclinical tumor that's not really detected by all the diagnostic approach that we are doing, the traditional ones. And we really need to work on the stage of this phase and try to reverse it back into elimination. And that's why we're talking about putting together a cocktail of polyphenols, of methylene blue, of low-dose naltrexone, of all those ingredients that we think CBD, and give it to the patients on daily doses, because it's very critical, especially knowing that 50% of us are going to have cancer. 50%, that's a big number. And we need to reduce that number by coming up with something that's going to be medical necessity, that everybody has to take it. It's going to be part of our regimen, not luxury thing, but something that every person above 50 years old, especially because that's where the cancer most of the time comes after 50, needs to be taking it in order to lower that percentage of 50% of the risk of developing cancer. And moving the face of equilibrium back to elimination. If we start taking those cocktails of polyphenols and losartan, methylene blue, we're going to discuss how and why all those drugs works and how it works. If your cancer cells are able to evade the immune system, that's called escape, and that's where the immune system is unable to catch up with the growth of the tumor, and that's what the patient has, full-blown cancer or clinical cancer. And we really need to stop that from happening. And it's better if we stop it from moving the equilibrium back to elimination, because once the cancer is developing and growing, it's really hard to control with all the methods that we have. And the success rate of managing cancer, it's very poor, it's very low, even up today. So we need to work in the beginning and prevention instead of letting the tumor escape the immune system completely. And so we know for the fact that immune system is checking on every cells on your body, and if it become weird and foreign and tumorless, then your immune system will start detecting them and eliminate them, right? So how they eliminate them, macrophage will eat them, and the macrophage, when they eat those cancer cells, they secrete interferon gamma, and then interferon gamma can activate the natural killer cells, and natural killer cells can kill those cancer cells, non-specifically. That's the innate immune system. But then also your macrophages, when they eat those cancer and they start breaking the antigen of the cancer, and they start expressing it on their surface, on their major histone Blvd complex type 2, and they're presenting it to the naive T cells, and naive T cells will differentiate into Th1, and then Th1, along with the macrophages that's being active, M1, they start secreting chemicals, interferon gamma, interleukin 12, and that will activate the cytotoxic T cells, and then cytotoxic T cells will catch that cancer, will combine with that cancer, and will destroy the cancer by secreting chemicals that will open up pores into the cancer membrane and blow them up. So that is called the cytotoxic immune system. That's how we are killing cancer. So it's very important in killing cancer that we have to have functional Th1, M1, and cytotoxic T cells. Antibodies and neutrophil will not do that much killing the cancer as the cytotoxic T cells. So it's very important that the immune system has to be kept polarized into M1 and Th1, and anything that prevents it from polarizing to M1 and Th1 and cytotoxic T cells, that will lead to immune suppression that leads to the cancer to flourish and growth. And we're looking for all the protocols and all the drugs that will help to polarize the immune system all the way to Th1, M1 in order to get rid from those cancers. And so your immune system has to be all the time balanced and has the capacity to polarize Th1 cytotoxic T cells at any time. If you are getting sick, or you are your immune system is being compromised, and your immune system is unable to polarize into Th1, M1 for a certain reason, maybe because being sick is your cortisol is high, that suppressed the immune system, then that's where the opportunity of the cancer can emerge and develop. So keeping us, or keeping your patients and humans in general and the public healthy is very important, because that's the way we can prevent the cancer from emerging. So sickness and immune suppression and bad lifestyle that we have, the lifestyle that we're living, the diet that we eat, all of this can affect your immune balance, and it will suppress your immune system, and that's where the cancer can take advantage over that and escape your immune system. So that's what we call the elimination. And equilibrium, your tumor cells, there is some growth, but it's the number of the cells that's growing as cancer is equal to the number of the cells that's dying by your immune system. So that's the equilibrium phase. And it's very important to shift the equilibrium phase to elimination phase using all the protocol that we're talking about. Is your lifestyle needs to change, diet needs to be changed, maybe a cocktail of supplements and certain drugs, anti-cancer drugs that we know or we're going to learn about it, that may help to shift the phase from equilibrium to elimination before it escapes, before the tumor escapes the immune system. So what makes the tumor escapes the immune system? Well, the tumor cells, they have many mechanisms of escape. I'm going to talk about them. But one way is that the tumor antigen is not immunogenic. It's not that much different from your normal cells. So your immune system cannot recognize it as a foreign. And that's why we call low immunogenicity of this tumor. And that's where the immune system cannot be polarized into Th1 and 1 or cytotoxic T cells because they don't recognize them as foreign. So it's low immunogenicity. That's one way that the tumor can escape the immune system. But there are many other mechanisms. And then you don't have enough of immune system that specifically can eliminate that cancer cells, and that cancer cell will start growing and proliferating. But that's one mechanism. There's many other mechanisms beside low immunogenicity of the tumor cells. There is other mechanism we're going to talk about. It. One of them is that the tumor secretes blockades, antigens, or checkpoint that on the surface that will turn off your cytotoxic T cells, and that's like PD-1. When they react with cytotoxic T cells, it's like a key in the lock, and they turn off the cytotoxic T cells. They suppress your cytotoxic immunity, and that leads to the tumor to escape the immune system. So that's one way. The other way is tumor may secrete interleukin 10, interleukin 6, and polarize the immune system away from Th1 and 1. Polarize the immune system to Th17, producing neutrophil. What I want to do with neutrophil? Neutrophil cannot kill the cancer. Or polarize the immune system into Th2 and produce immunoglobulin, histamine. So what I want to do with histamine and immunoglobulin E will not kill that cancer. So your cancer cells will secrete chemicals that will polarize the immune system away from Th1 and M1. So that's one of the way that the tumor can escape the immune system. And you see here, those are the mechanism of escape here. If you see it here, is one is of course the tumor cells. It become less immunogenic. So that's one way. The antigens that they produce have not been recognized by the immune system as immunogenic. It will not activate the immune system. So that's one. So reducing tumor antigen. The other way is that those cancer cells, in order to become cancer, they really have to increase the bar of the apoptosis. Normally, the cancer cells, how they die, they generate free radicals, and the free radicals will stimulate apoptosis and kill the cancer, right? But what happens if the apoptotic genes, they are resistant to that free radical that's supposed to stimulate apoptosis? Those apoptotic genes, they are becoming redox insensitive, and you need a really higher free radicals, higher in order to kill that cancer. So there would be a problem in apoptosis. So you have apoptosis resistance, right? So in order to kill that cancer, you need to have, for example, have photosensitizers accumulating the cancer, generating enough high free radicals to kill that cancer. That's one way. Or radiotherapy. So you need to have high free radicals, because the normal free radicals that kills the normal cells, it's not enough to kill the tumor cells. And that's why we use chemotherapy, radiotherapy, and photodynamic therapy to increase the free radicals enough to induce apoptosis in the tumor cells. The other thing, you may have problems and mutation in the oncogenes. The oncogenes are the genes that are responsible for the cell proliferations. Normally the cells, when they reach a certain divisions, they stop. by contact with the surface. That signal will stop them from dividing, and that prevent the cells from going crazy and unstopped division. So the cells do stimulate to the external stimulus, and that control the oncogenes that control the cell proliferation and the cell cycle. But in case that you have mutation in that genes where they're not responding anymore to the external signals, and then the cells will start dividing uncontrollably, and they would have that tumor, right? And so we need to work on that too. There's lots of drugs that does inhibit the cell divisions, and whether it's chemotherapy or other repurposing drugs in managing tumor. The other thing is that the tumor can secrete cytokines. We talked about them: interleukin 6, interleukin 4, interleukin 10, and polarize the immune system away from Th17. So that's one way, is by secreting those suppressing cytokines that polarize the immune system into Th17 and neutrophils. So what do you want to do with neutrophils? Neutrophils cannot kill the cancer. Or the tumors start expressing PD-L1 or CTLA4 or PD-L1, for example, or PD-1. And PD-1, when they react with PD-L1 of the cytotoxic T cells, they turn them off. Those like a key lock, they turn off the cytotoxic T cells. And when you turn off the cytotoxic T cells cannot kill those cells anymore. I'm going to talk about it and see how we can block those PD-L1 by using antibody blockades that will activate those cytotoxic T cells and regain their functions and kill the cancer cells using those specific antibodies. Tumors also secrete prostaglandin E2, and prostaglandin E2 does polarize the immune system away from Th1M1. So when the macrophages in an environment of too much of prostaglandin 2, they polarize into mReg instead of polarizing to M1. And the other thing is that you would have the fibroblast also, so the tumor microenvironment. We talked about the fibroblast and how the fibroblast secretes fibrosis, and the fibrosis squeezes the blood vessels, and the blood vessels, when they're squeezed, they prevent the lymphocytes from infiltrating the tumor. Then you will have a cold tumor because you don't have enough of lymphocytes going into the tumor, because the fibrosis is squeezing those blood vessels. And those fibroblasts also, they can secrete chemotaxis chemicals that will attract those suppressive cells, those Tregs. And those Tregs will inhibit the cytotoxic T cells. And they will inhibit and polarize the macrophage into mRegs. Even M1, they turn them into mReg. They turn them off. Those Tregs can turn the M1, which is the effector, which we needed for killing the cancer, into mReg, which is the suppressor macrophages. And that will definitely suppress the immune from attacking the cancer. So all of these methods, all of this the way of pathophysiology, we need to learn about them, because then we can start developing drugs and protocols that would help to block this and reverse all those methods and way the tumor is tricking the body and polarizing the immune system away from M1 and Th1, as you see it here. All this needs to be reversed by drugs, whether it's chemotherapy, whether they're repurposing drugs, what we talked about, or the antibodies that would block the PD-1. And we're going to talk about all those protocols and how we can navigate all those methods that the cancer is using, all the tricks to escape the immune system. So here we have the immune therapy. It could be passive or it could be active. And passive, we're going to talk about it. Passive immune therapy is where you are providing immune therapy from outside the body to do the work. While active immune therapy is inducing your immune system to react and to kill the cancer cells. So either you are bringing immune therapy from outside the cells, whether it is antibodies or virus or T lymphocytes from outside, and they will attack the cancer cells of that patient. So bring it from outside. That's a passive. Like giving anti-serum to the patient who has virus infection versus giving a weak antigen, which is a vaccine that would activate the immune system to kill the cancer. So there's passive and active. When we give antibodies to the patient, that's passive because antibodies will kill that cancer or kill that virus. So that's passive immunity. When you are activating your immune system of the patient, activate the immune system of the patient to produce cytotoxic T cells or antibodies, then that is an active immune therapy. And so in immune therapy, we have two kinds. We have passive immune therapy and we have active. A passive is using anti-tumor antibodies. So yes, antibodies can kill cancer, but is that enough? No, you need to really have cytotoxic T cells. So just antibodies is not going to be enough. Or you can have multi-specific antibodies where that antibodies will take the macrophage and T cells and the cancer cells and bring them all together and activate them and kill the cancer cells. Or you engineer viruses. There is viruses already, by nature they are engineered, and you give them to the patient, and those viruses will specifically infect those cancer cells. So there are some of them are natural virus that has tropism to the cancer cells, or man-made engineering of viruses where they will have tropism and attraction to the cancer cells, and then they attack them and destroy them. The other thing you can do is using CAR cells, CAR T cells and TCR. We're going to study them in the coming slides. Or you take T lymphocytes from outside, from another patient's, and you give it to the patient with cancer. So those T lymphocytes will attack and destroy the cancer cells of the patient. We're going to study each one of these of this passive immunity. Okay, are you there, guys? Can you hear me? Maybe. Okay. I don't know if anybody. Can you hear me, guys?
I hear you fine.
Okay.
Loud and clear.
Okay, great. So, so we're going to talk about active therapies and passive therapies, and we know that the active therapies are therapeutic vaccines, and we're going to talk about how we can develop vaccine for tumor. We're going to talk about the cytokine treatments, giving patients interferon gamma or interleukin 12. All those cytokines to really activate the immune system of the patient to kill the cancer. And we're going to talk about the antibody blockades, which is the antibodies that will block the PD-L1 and CTLA-4, and we're going to talk about them in the coming slides and details. So we can use either passive immunity or active immunity or immune therapy, or we can use both passive and active immune therapies together, which is better. The more tumor, the more you combine your therapy, the better. Monotherapy is not working for cancer. Radiotherapy by itself is not going to work. Chemotherapy by itself, photodynamic therapy, it's better if we do all of them. So we can really target that cancer cells from all different angles. So monotherapy in cancer is not working. And the way that Big Pharma is enforcing us to do monotherapy is not really for the best interest of the patient or to heal the patient. It's to get data. You're giving data that this drug works by itself. And that's what they need, because if you do it combined, then those Big Pharma cannot prove to FDA that their drugs is working. So that's why they are interfering with our regimen and they are telling to the oncologist, oh, you only use this drug. You cannot use it with other things if you use this. And they're dictating the regimen. So is that regimen that they're dictating is for treating the cancer or for approving that drug so that company makes money and prove the drugs for the FDA? It's really most of the regimen that's being adapted by the mainstream medicine is really to prove that drug. That's why they tell the patients, oh, if you take this, you cannot go to other doctors or other integrative doctors and taking CBD or taking other drugs. You have to keep taking this. And if you do take other drugs, that other doctors think it's the best interest for you to combine it. That's what we do and for treatment. Then they will dismiss you. And they say, okay, you know, you are not our patients anymore, and they will not work with you because or work with the patients because it violates the regimen that's being dictated by the big pharma. So that is where us as integrative doctors are different. Our integrative doctors, we don't care about what the big pharma is telling us. We care about how we can treat the patients. And if combining therapy will work and helps to heal the patient, cure the patient, that's what we are looking for. And that's why we call ourselves integrative doctors, or we call ourselves as chronic disease prevention management doctor, or regenerative doctor, integrative alliance doctor, whatever name. Our interest is the patient. So so we go in here and see the passive therapies. As we said, it could be by giving patient antibodies, and just naked antibodies. And those antibodies will attack cancer and opsonize the cancer cells and possibly activate complements and make holes into cancer cells and kill the cancer. So that's one way, is giving antibodies. Although antibodies by itself is not that effective in killing cancer. You really need to have cytotoxic T cells in order to kill cancer effectively. Or you take the antibodies, and all of this are passive immune therapy. You take antibodies, you add them radioactive, and those antibodies will link to the cancer, and those radioactive substance will radiate and increase the free radicals in the cells and induce apoptosis and kill the cancer. Or you link the antibodies with toxins. So when the antibodies attach to the cancer cells, those toxins will make holes into the tumor and blow them up. Or you have chemotherapy and you link it to the antibodies as a target therapy of chemotherapy, right? You want to direct those chemotherapy to go into the cancer. So they take the antibodies and they use it as a targeting agent to deliver those chemotherapy into the cancer. And that's called target therapy. It needs to be done in the big pharma, of course, in the lab. Or if I want to have cytokines like interferon gamma or interleukin-2, and I want to get them all into the cancer cells, I can link the antibodies and give that way. Or I will give antibodies, and that will opsonize the tumor, and then this will cause attraction of natural killer cells, and natural killer cells will kill the tumor. So that's another way. Other thing is that those antibodies will activate the complements, and our complements will make holes into the tumor and destroy them. So this is how, this is what we call the passive immunity. Those are methods that we are using for passive immunity here, using antibodies. But also we can kill cancer passively by either having virus that naturally have a tropism of attaching to the cancer and destroy the cancer. And there's a lot of companies are developing those viruses. They are adenoviruses and many different kind of viruses that has tendency to attach to the cancer and proliferate and divide inside the cancer cells and kill them. So we can infect those cancer cells with those viruses that naturally has a tropism to the cancer cells, or we take those viruses and we engineer them. We give them receptors that will have tropism to the cancer cells and destroy the cancer cells. And there is some success of certain cancer using viral And as you see here, the virus will infect those cancer cells and they will proliferate, divide, blow the cells, and also activate the immune system by doing that, right? Okay. The other option is giving antibodies that will attach to the cancer cells, and also that will attach to the T cells and to the natural killer cells. So bringing all those components, natural killer cells and T cells, to kill the tumor. So the antibodies, it helps to put those components, the cancer cells, together with natural killer cells and bring them toward the cancer cells to destroy them, and T cells to destroy the cancer cells. That's one way that those antibodies can be engineered to bring the cancer cells next to natural killer cells and to the T cells, as you see it here. And that's one way of killing cancer. The CAR cells, or CAR T cells, you know, those chimeric antigen receptors. And what is it? It's what happened, especially in hematological cancers like leukemia. Their cells are those tumor cells. They are not immunogenic. Those tumor cells, their major histocompatibility complex is being defected, and so they're not good in presenting in other words, they're not good in presenting the macrophages themselves are not good in presenting those antigen to the immune system, and because of that, we can go ahead and engineer those T cells, especially the cytotoxic T cells, and have them attacking those cancer cells regardless. So let's say leukemia, in order for cytotoxic T cells to attack and destroy leukemic cells or cancer cells, those leukemic cells or cancer cells, they have to present their antigen in major histocompatibility complex type 1. And then the cytotoxic T cells will be able to combine with both, with the antigen and the major histocompatibility complex type 1. If those cancer cells are not developing, the major histocompatibility complex type 1 in a normal way, and there's defect there, like those leukemic cells, they don't really develop very good, they don't have that very good major histocompatibility complex type 1, it's defected. So the cytotoxic T cells cannot recognize them and destroy them, because the cytotoxic T cells, the T cell receptors, they can only attack a cancer cells that has intact major histocompatibility complex type 1 and the major histocompatibility complex presenting the tumor antigens. Okay, so in that case, what I need to change the cytotoxic T cells in the way that they will combine with the cancer cells regardless of their major histocompatibility complex. Like those leukemic cells, they don't develop well, they don't have a good major histocompatibility complex that present their antigens. So what I would do, I take the cytotoxic T cells receptor, the T cell receptor, and I will engineer it. How I engineer it, I will take the outer portion of the cytotoxic T cell receptor, the T cell receptor, the lymphocytes receptors, and I will put antibodies. I will keep the inside, the genetic makeup of the inside of this cytotoxic T cell receptors, but the outside, I will engineer it so it will look like antibodies. Antibodies, they don't really need major histocompatibility complex and the tumor cells to be presenting it to the cytotoxic T cells. Antibodies can attack with any antigen that's foreign, but you don't need to have it presented in a major histocompatibility complex type 1. And that's the beauty of it. So the CAR cells is cytotoxic T cells, a hybrid of antibodies and a cytotoxic T cells, where the outer portion is antibody of the receptor, the inner portion of cytotoxic T cell receptor is still, it's a cytotoxic T cell, that portion is still there. And so what will happen, those cytotoxic T cells can easily combine with the leukemic cells and destroy them. The same mechanism of cytotoxicity or cytotoxic T cells, that what they do, they secrete cytotoxins that perforates and make holes into the membranes of the cancer and blow them up. So that's what I call the CART chimeric antigen receptor. And so what we do, we take the blood from the patient and we get the cytotoxic T cells, and then we engineer those cytotoxic T cells. We infect them with maybe antigen or genes that will express cytotoxic T cell receptors, we call CART receptors, that the outer portion is antibody, the inner portion is the T cell receptor. And we inject them back into the patients, and we can have better results in destroying hematological cancers, which is the leukemia, lymphocyte, lymphoma, but we don't see much success in solid tumors. Okay, so those are the other way of doing it, or other way of enhancing your immune system, or in other words, or developing what we call a very effective cytotoxic lymphocytes. So we know the cytotoxic lymphocytes, if we can make their receptor more effective in attaching the cancer cells, especially when you have a cancer cells that has low immunogenicity, that the cytotoxic T cells of the patient is unable to recognize them because they are low immunogenic. And that way we can go ahead and take those cytotoxic T cells or T lymphocytes, cytotoxic T lymphocytes, and then engineer them, infect them with genes that will express more effective T cell receptors. That is more effective. They're not antibodies, they're T cell receptors, but they're more robust in attacking those low immunogenic tumors. We can have better results by engineering and reinforcing or making the T cell receptors more effective in combining those tumors with low immunogenicity. And then, of course, when those cytotoxic T cells, those robust engineered cytotoxic T cells combined with the tumor, they secrete those cytotoxins that will blow up the tumor and cause the tumor death. So that's one way of doing things. The other thing is taking the lymphocytes, take the blood from the patients and isolate all the lymphocytes, okay? And then what we do, we treat them with in vitro, with interferon, interleukin 2 or interferon gamma, and make them more enhanced. It's like training soldiers, right? You take the soldiers, you train them, they become special forces, like what Putin is saying, special forces operation. Same thing. So you take those lymphocytes from the patients and you train them, you expose them to interleukin 2, so they become special forces, special enhanced cytotoxic lymphocytes and T lymphocytes in general, or more enhanced natural killer cells that's being treated with cytokines that stimulate them, and then you give them back to the patient. So all of this is passive immunity. You are giving to the patients immune therapy from outside. You're not activating the patient's immune system. The patient's immune system is not the one attacking the cancer. It's the immune therapy that you are giving it to the patients, whether it is cytotoxic immune therapy or it is antibodies immune therapy. But when we are talking about active immune therapy, that means you're activating the immune system of the patient to attack and destroy the cancer. And we can do that by giving the patient cytokines, right? You give them interleukin 2 or interferon gamma, you give them thymosin alpha. So all of this is cytokines. The FDA, I think they approved interleukin 2 and interferon gamma. The ganocyte, of the granulocyte or the monocyte, the colony stimulating factors that is not being FDA approved. But the interleukin 2 and interferon gamma are the two cytokines that you can inject them into the patients. It would be nice if those cytokines and those antibodies that we talked about, all of them, it's good if we load them inside platelets nanoparticles and giving them to the patients in the form of nanomedicine, which is better because those platelet nanoparticles loaded with antibodies or loaded with cytokines, loaded with photosensitizers, or loaded with chemotherapy, whatever, you can load anything, right? And in a cargo, and they're on the size of platelet nanoparticle, the size of 100 nanometer, around that, they have more tendency to carry all those loaded drugs, all those drugs into the pathology, because the pathology, whether it's cancer, infection, or inflammation, their blood vessels are leaky to this size of nanoparticles, which is around 100 nanometer. And loading inside the platelets nanoparticle, I think is the best option, best way. So you can get them into the pathology, because the normal tissue, their blood vessels cannot really allow those big particles to pass through. They're more tight. They're not leaky, but the pathology are leaky. So those nanoparticles can get into the tumor without getting into the normal tissue. And that minimizes side effects. Because if you give naked chemotherapy, if you give naked antibodies, it goes everywhere. And then you have the side effects that you don't want. And then you dilute those effects of the chemotherapy or antibodies or cytokines that you're giving. And so it's better if we load them inside nanoparticles. And the best is platelets nanoparticles, not the phospholipids or PLGA, the synthetics, because the synthetics still, they be recognized by the body as foreign. So the macrophages in the liver will take them, and the lung will take them, and they don't get into the target pathology. It's better to use their own natural phospholipids, membranes of your red blood cells, or the platelets better than red blood cells. I did a lot of work on red blood cells. It's not that effective as platelets. And we have the technology to do that. If you need to be trained, we can help you with that and get you trained to do nanotechnology. And we have a lot of doctors are doing it, and with great success. What else? We have also therapeutic cancer vaccines. So what we do, there's many ways. You can do it in a big pharma way, where they take the dendritic cells and then they engineer them. They infect them with a virus that express the antigens. So those dendritic cells were already being sensitized to the tumor antigen. And then you inject them back into the body, and then the dendritic cells will activate your immune system, polarize it to Th1 and cytotoxic T cells, and kill the cancer. So this is one. It's called dendritic cell therapy. So you take you take the monocytes from the blood, and then you grow them in vitro, and you add them platelet lysates. When you add them platelet lysates and you incubate them, they become dendritic cells. Those monocytes and those they become dendritic cells in vitro, and then you can go ahead and expose them to the tumor antigens, or infect them with the virus, or change their genes by CRISPR technology, and introduce the genes of the tumor to those dendritic cells, so they become sensitized. As integrative oncology, the way we can do it, so we don't need the engineering and labs of the big pharma, we can take tumor and take the tumor biopsy, and then do tumor lysis by sonication, and then sensitize your dendritic cells culture, which is incubated with platelet lysate. So platelet lysate is so easy. Take platelets, you break it down and get the platelet lysate, and incubate it with your monocytes that's coming from the blood, which will turn into dendritic cells. And then you take the tumor biopsy, you sonicate it very powerfully, and then you nano it, of course, nanofilter it, and then you sensitize those dendritic cells. And those dendritic cells will become sensitive to that antigens. They're ready. And you inject them into the body, and what will happen? They will activate the naive T cells and polarize them to Th1, and then Th1 with dendritic cells with M1 and the DC ones, definitely will activate the cytotoxic T cells and kill the cancer. So that's one way of doing it in a clinical level, instead of doing it in the lab where you need all the sophisticated lab. The other thing that we need to learn is to, or use to kill cancer, is to block those the PD-1 and CTLA-4 with antibodies. And I think we talked about it before, is that those tumor cells, they express on their surface antigens, we call them PD-1. And when this PD-1 combined with PD-L1 of the cytotoxic T lymphocytes, what will happen? They turn them off. So let's say you have a tumor is being attacked by cytotoxic T cells, right? And what will happen here, as the T cell receptors is combining with the antigen of the tumor on the major histocompatibility complex type 1, there is, in this T cell receptors, there is co-stimulators and co-inhibitors. And those co-stimulators do activate the lymphocytes, the cytotoxic T lymphocytes, and the co-inhibitors, they will inhibit the cytotoxic T lymphocytes. And if the tumors is expressing PD-1, they will react with PD-L1, which is the co-inhibitor, and they will cause, or they will turn the cytotoxic T cells off. So those tumor cells, yes, you will see, are attached by cytotoxic T cells, but they're being turned off by the PD-1, PD-L1 reaction, which is PD-1 from the tumor, PD-L1 from the cytotoxic T lymphocytes. So what I will do to turn on the cytotoxic T cells and activate them at day so they can kill the tumor cells is to develop antibodies that blocks either the PD-1 or PD-L1. And we have it. It's an FDA approved. And we can go ahead and give it to the patients. And Dr. Patel is one of the doctors in my group. She's doing it. And she's giving those PD-1 inhibitors, those antibodies, to block those PD-1, those antigens expressed by the tumor. So they prevent the tumor from inactivating and putting the brake on the cytotoxic T lymphocytes and activate the cytotoxic T lymphocytes to kill the cancer. The other thing is that the Tregs, they do have CTLA-4, and they inhibit those macrophages, the M1, and turn them into Mregs because of the CTLA-4. So what I will do to prevent that from happening and preventing those macrophages from being turned off and become Mregs is giving antibodies that blocks the CTLA-4, and that will turn on those macrophages and switch them from Mreg into M1, and that would help to activate the immune system to kill the cancer. So giving both, giving anti-PD-L1 or anti-PD-1, giving anti-CTLA-4 would definitely help to enhance the immune system in attacking and destroying the cancer. Again, here's the problem, okay? The problem of giving those antibodies nakedly, as they are doing currently right now with great excitement of what we call them immune oncologists, they call themselves immune oncologists, is that when you give those antibodies, especially when you give CTLA-4 antibodies, for example, yes, you will be activating your immune system. Yes, you will be turning your you will be activating and turning the Mregs into M1s, and you will be activating the cytotoxic T cells to kill the cancer, but also you're activating the immune system to attack your self-antigens. So when you give those antibodies, it does help to kill the cancer. But at the same time, it will reactivate the immune system to kill or attack your self-antigens. So what we need exactly, we need to deliver those antibodies, those blockade antibodies, into the cancer tissue. And how we can do it? Using nanotechnology. Load them inside nanoparticles, inside the cargo, inside an envelope. And that envelope will go specifically to those leaky tissue, which is the cancer versus the normal tissue. And that's what Dr. Patel is doing currently. And that will distinguish her from other doctors. So the other doctors, they do giving it naked, and they end up with reactive colitis and trigger autoimmune diseases, and that will definitely deplete the immune system again and cause the cancer to flourish. But if you can get those antibodies into the cancer tissue, then you will spare the other immune system that is very important to be kept tolerance to your self-antigen. And that's the problem with those antibodies currently. And the only solution right now is using platelets nanoparticle. There's a company who's doing it. Mainstream companies working on it. It's called Therapeutic, I think. And they are developing this technique of platelets nanoparticle. But they're using PLGA to make those platelet nanoparticles more stable. In clinical, we don't need it because we're not selling the drugs. We're just mixing it and giving it to the patient immediately. So you don't need to have a long life shelf. So I don't think you need a PLGA. But this is the best way of delivering drugs into pathology using nanotechnology. So again, we can use, so there's many antibody blockades. As you see here, when the cytotoxic T cells combine to the tumor, there is co-stimulators and co-inhibitors, and we need to develop antibodies that will activate the co-stimulators and inhibit the co-inhibitors in order to keep those cytotoxic T cells active, destroying the cancer. And so there's only a few of those antibodies being developed, which is PDLA and CTL4, which is here, I think, right? It's called pembrolizumab and ipilimumab, your VOI and Keytruda. Those are two drugs that's been FDA approved, and I think Dr. Patel is using it with great success. So it's very important to look at all those methods of treating cancer and use them all. In addition to that, beside the immune therapy, beside the metabolic therapy, which is chemotherapy, beside the radiotherapy, beside the photodynamic therapy, we also need to focus on changing the tumor microenvironments to make it a hostile environment instead of being a favorable environment for the tumor. And the tumor cells do secrete chemicals that makes the environments favorable for the tumor to grow. They secrete chemicals that will polarize the immune system away from Th1 and M1. We talked about them. They turn into becoming Th17 by secreting interleukin 6, or Th2 by secreting interleukin 4, or interleukin 10, Tregs. And we need to go ahead and polarize them back into Th1 and M1. We use low-dose naltrexone to inhibit the Th17. That helps to polarize the immune system indirectly to Th1. So when we're giving low-dose naltrexone, I don't like to say it will polarize the immune system to Th1 or Th2. I like to say it inhibits Th17. And if doing that, then this would help to polarize the immune system to Th1, right? When you are stopping the tumor from polarizing the immune system to Th17, then automatically they will be polarizing into Th1 and kill the cancer cells. So that's why low-dose naltrexone works in polarizing the immune system to Th1. But indirectly, by inhibiting the Th17. Or giving antihistamine. What are giving antihistamine?
Dr. Halasa,
Yes, go ahead.
you said that what to give for changing Th17 to Th1?
No. When we have tumor, we know the tumor cells secretes interleukin 17, interleukin 6, and they polarize the immune system away from Th1. You got my point?
Right.
Okay, so what I will do in order to keep the immune system moving to Th1 is to inhibit the Th17. And if you do that, then those naive T cells will be available to be polarized to Th1 instead of going to Th17 and useless immune reaction. That's inflammation that will not kill the cancer, those neutrophils. We need cytotoxic T cells. So if you inhibit that polarization of Th17, which is induced by the tumor cell, it's a way to avoid the cytotoxic T cells, right? You polarize them away from them. And those cancers, that's what they do. It's the same like COVID virus. The COVID virus is what they do. They have the ACE2 activating angiotensin, which leads to indirect activating overactive of angiotensin type 2-1, angiotensin 2 type 1 receptor, which leads to production of interleukin 6, polarizing the immune system away from cytotoxic T cell, which is very important to kill those infected cells with this COVID-19 virus. So the virus of COVID works the same like tumor. Both of them
they activate Th17 and polarize the immune system Th17 by producing interleukin-6, which will exhaust the immune system and preventing it from moving to the right direction, which is Th1, M1 cytotoxic T cells. You got my point? So
Yes.
what we're doing, we're inhibiting that polarization to keep the polarization moving to Th1, M1 cytotoxic T cells. And that's what we do in those low-dose naltrexone, for example, or methylene blue, or ivermectin, or we're using hydroxychloroquine. All of these drugs do inhibit the Th17. Now, the beauty, if you hear the lecture of Dr. Bill, which is, he has a very nice slide where he shows all the common pathophysiology. This is how you look at the pattern. Common pathophysiology of degenerative and autoimmune and cancer and allergy is overactive Th17. Overact, and if you inhibit that, you can help to manage the patient. It's not completely, it's just an adjunct, but of course you need to work on other things. But this helps to definitely improve the patient's condition just by inhibiting the useless polarization and overactive polarization of Th17 and interleukin-6 and neutropenia. Because interleukin-6, if it's overactive, it causes coagulation, it causes fibrosis, and both fibrosis and coagulation is not good. Because fibrosis will squeeze the blood vessels, so preventing the lymphocytes from infiltrating the tumor. And then coagulations, the platelets, when it's being active, it will form a shield around the tumor and preventing it to be exposed to the cytotoxic T cells. So overactive interleukin-6 is not good. And that's
What
why.
about peptide? What about peptides?
So yes, so that's what I'm talking about. So let's say in the tumor, you have the polarization of the immune system going to Th17 and it's going to Th2 and Treg, right? So what you need to block the Th17, right? But also, do you have drugs that will help the polarization of the immune system to Th1? So you need to do that. So you need to block all the pathways that is away from Th1M1. You block the pathway of Th17. You block the pathway that goes to Th2. You use antihistamine. You block the pathway that goes to the Th17, which is low-dose naltrexone. But also, do we have drugs that polarize the immune system to Th1? Yes, we have interferon gamma, we have thymosin alpha, but very important. When you give interferon gamma, here's the problem. It increases the expression of the tumor cells to the PD-1, which will switch off their tumor cells. So very important, you give antibodies against the PD-1. So you give the Keytruda and you give the interferon gamma together. You have more effective. But if you give interferon gamma by itself, yes, polarize the Th1 and you give the cytotoxic and you get enough of cytotoxic T cells, but then the tumor, what they do, right? They will turn it off, the cytotoxic T cells, by expressing the PD-1 on the surface and turn off the cytotoxic T cells. And that's where one of the things about people who are doing the CBD, the cannabinoid do inhibit the expression of the PD-1 on the tumor cells. That's a beauty thing. That's a good thing. So if you do CBD and you do with it low-dose naltrexone and you do interferon gamma, all of this would help in managing the cancer. So you need to learn all of the tricks of the cancer and try to reverse it. But just shooting in the dark and following the regimen of the big pharma who are dictating the monotherapy to get data, they don't care about the patients. All of that needs to be, dismissed, and we need to get all those information, all those recent publications, and learn and translate into protocols, which you are doing, Dr. Patel, with great success.
So in other words, if you are not using interferon gamma, you should not be using the TA1 or thymosin alpha?
No, you can still use the thymosin alpha and interferon gamma together. They will help the polarization of Th1 synergistically.
But then you said that also it stimulates the PD.
Yes, so they will stimulate the PD-1. So that's mean expression.
You give the blocker, okay.
So you need to add the blocker, the anti-PD-1 antibodies blockades.
In this previous slide, it said PD-1 blocker, Keytruda. Keytruda is PDL1. So
well, either way, PDL1 or PD-1. There is
Right,
antibodies for PD-1 and
right,
PD-L1.
right. But
I don't really care
the
about the name and
PD-1 is
commercial name. Yes,
PD-1 is a nivolumab, which is
Right.
Opdivo. Right.
right. So either way, you block that, you activate the cytotoxic T cells, and you kill the cancer. But giving interferon gamma by itself, that's where the problem is. Now let's go back to say this is for the lecture of last night, which Dr. William Bell, and I slept in the middle of his lecture. I don't know what happened to me, and I feel guilty about it. So I apologize for Dr. Bill about it. Well, because I was ready to add those things because he has it all in his slides, and we just need to discuss it and talk about it. The other thing is that in allergies, you have Th2, which is Th2 dominant immune disease, but also you have some Th17 as well. And in allergies also, if you give low dose naltrexone would help the patient. But of course, you still need to inhibit the Th2 in allergies. And in autoimmune diseases like multiple sclerosis, there's Th1 and Th17. So if you inhibit the Th1 only, it's not going to work, which they did it. They inhibited with antibodies that blocks interferon gamma, and the disease it ended up become more worse because you still have an active Th17. So you really need to inhibit the Th17. So you need to block the Th17 and the Th4 in order to really effectively manage multiple sclerosis and manage rheumatoid arthritis. So Th17 is actually everywhere, even autism, there is overactive into Th17 and interleukin-6. That's why low dose naltrexone works. Now, well, low dose naltrexone is not just inhibiting Th17 and interleukin-6 production, but also it has other activities. Of course, it activates the AMPK. We know about it. We talked about it. We have a big lecture on it. It also low dose naltrexone. It does help to induce apoptosis and kill the cancer cells. So there's many other activities, and it does increase the expression of the opioid receptors, and that's good for pain, right? And increases sensitivity to pain. But Dr. William said he increased the encapsulants. I think it's more increasing the sensitivity to the opioids and to the encapsulins and endorphins by increasing the expression of the opioid receptors. Those are the things that
So Dr. Bill also mentioned that if you give the naltrexone and CBD, and then there was one slide, it said that if you give there was a study, if you give CBD first and then you give the naltrexone, there was only 22% inhibition. Whereas if you give naltrexone first, and then followed by CBD, there was 35% increase. Right. So if one is going to use it, one should use the naltrexone first, followed by the CBD.
Right, because naltrexone possibly it increases expression of the CBD receptors as it decreases expression of the opioid receptors. So that's the beauty of it. So that's the mechanism. So you're increasing the sensitivity of the CBD with naltrexone. So people are doing that both together are more effective in any applications, including alcohol addiction. You would use both of them, it's better.
What about the mitophagy? Can you talk about in relation to about the mitophagy? So
well, again, naltrexone, if it activates the AMPK, which is the adenine monophosphate kinases, then it does help in activating the mitophagy in general. It could be it causing stimulation of the mitophagy directly of the mitochondria, but just activating AMPK leads to activation of the mitophagy and the mitosis by blowing up. Mitophagy is blowing up the mitochondria and releasing the cytochrome oxidase, which will induce apoptosis of the cells. So it seems like naltrexones and the polyphenols and the CoQ10, all of them works on the same mechanism by blowing up the mitochondria and inducing the apoptosis. So it seems like naltrexone.
That's where you use the metformin, right?
You use metformin, you use CoQ10, you can use low-dose naltrexone, use polyphenols. They all works in that similar pathway. Again, combining all this cocktail, that's why we want to develop cocktail for prevention, which we can just use it as an oral dose. But when you go to cancer treatment, I like IVs. I like high dose. I don't want to go with low dose. I like high dose because high dose curcumin, high dose, it's better because it generates the free radicals as well that you need to destroy the cancer. So if you do cancer treatment, it's better to do IV versus doing oral. If you do prevention of cancer, you can go ahead and get a cocktail and give it oral. That's how I see it. Because low dose curcumin IV is more effective than giving it low. High dose curcumin is more better than low dose curcumin in treating cancer and polyphenols in general. And also IV naltrexone is better than taking in tablets when you manage cancer. When preventing cancer, just give tablets. But when you manage cancer, I prefer IVs as much as I can. This is my perspective. I don't know if others will agree with that. But anyway, so when we're treating cancer, we need to go through stages. We need to kill the cancer so we can release those antigens, and then the macrophage will take them and eat them, and then presenting to the lymphocytes, right? And activate those lymphocytes. And we can enhance that process by doing vaccines, dendritic cells, right? Take monocytes from the blood, grow it in the platelets, lysate, turn it into dendritic cells, and then sensitize them with the cancer antigens, taking biopsy of the cancer and sonicate it, turn it into antigen, and then introduce it to those dendritic cells, and then inject them back into the tumor. And then we can activate the whole process also by giving cytokines, right? Whether you're giving cytokines in vitro to the lymphocytes, as we talked about the passive immunity, or you inject them into the body to activate your endogenous lymphocytes to kill the cancer. And then also, as we said, we need to block or use antibody blockades that will help to activate the immune system, activate the cytotoxic T cells, turn those macrophages from M-regs into M1, and inhibit the T-regs by using CTLA-4 antibodies. But again, if you're going to give antibodies, please use platelet nanoparticle. I think that's better. So, and then what you need to do, the next thing you need to do is, let me see here. You need to make sure those lymphocytes do infiltrate the tumor. So in order for the lymphocytes to be infiltrating the tumor and turn the tumor into hot tumor, not cold, because what does the tumor is they activate their fibroblasts, and the fibrosis is too much where they will squeeze the blood vessels, right? And also they just secrete too much of VEGF, which is vascular endothelial growth factor, and those VEGF will stimulate the blood growth vessels, but they are kinky blood vessels. What's that mean, kinky? That they are kinked. So yes, they will increase the sugar supply and nutrition supply to the tumor, but they will, because of the kinky thing, it will prevent the lymphocytes, because they're big in size, to pass into the tumor. And so we need to normalize the vasculature of the tumor by giving Avastin that inhibit the VEGF, the vascular endothelial growth factors. Not too much where there will be no blood vessels. Then if you don't have no blood vessels in the tumor, then you don't have lymphocytes going to the tumor. But normalizing it. So too much of VEGF will cause those vessels become tortuous and kinky, and they get easily squeezed by the fibrosis, and the lymphocytes will not be infiltrated. So you need to normalize it, but not too much of Avastin where you cause a decrease in the growth of the blood vessels, and there will be no way for the lymphocytes to go into the tumor. So you need to normalize it. And so the Avastin needs to be given in the dose that would normalize the vasculature, not to destroy the blood vessels of the tumor completely. Because if you destroy them in this method or with the technology, this protocol, then you will not allow the lymphocytes from going into the tumor. Although there's some treatment of tumor where you destroy them completely. Yes, if you destroy them completely, where there will be no nutrition and no oxygen in the tumor, that's fine. You do that. But don't destroy them where you get the nutrition there, but you don't get the lymphocytes.
we need the blood vessels to be big enough to allow the lymphocytes to infiltrate the tumor, so they turn from cold to hot tumor. So giving antifibrotic drugs like losartan is good. Shock waving the tumor is good, so you can break those fibroses and allow the lymphocytes to infiltrate there. And if the lymphocytes infiltrate there and you have all the cytokines, interleukin-4, the transforming growth factor, and polarizing the immune system away, then the immune system will not be affected. You'll see a lot of immune cells there, but they are inactive. So very important to polarize the immune system to M1, Th1, and activate them using the antibody blockade that we talked about. And then if let's say the tumor are not immunogenic, like leukemia cells are not immunogenic, the major histopathology complex type 1 is not perfectly well developed, they're defected. Then you may consider doing CAR T cells for those patients, or enhancing the T lymphocytes and create T lymphocytes that's active T cell receptors. That's the rebost. You can engineer them and infiltrate them into or inject them back to the patients. But again, it is very important to give all those drugs, whether it's chemo or photosensitizers or those repurposing drugs that would change the tumor microenvironments, or those antibodies that polarize the immune system to Th1, or any of those repurposing drugs. If you're giving anything injectable, please use the nanotechnology. And the best nanotechnology is using platelets, nanoparticles, which I can help you to develop that in your clinic, not just for cancer, but all different applications. So I think I'm done with part 1 of integrative oncology. It was a long night. I don't know if I was rambling here, but I was trying to simplify the information and then break it down to simplify it so everybody can really process it easily than just giving you hard terminology. Medical term. I try to break it down. I don't know if I succeed in that or not, but if not, just please ask questions, and we try to elaborate it and learn from you. And it's all about both ways. So go ahead. The mic is yours. And Dr. Bill, I know you've fallen asleep.
No, I'm here. Anybody have any questions? Comments?
This is Dr. Patel. Dr. Halasa, you repeatedly mentioned polarize the immune system to M1 to Th1, but how do you polarize M1?
The same drugs that you are using to polarize Th1, they are together. If you're able, the drugs that polarize to M1 is the drugs that polarize to Th1 and to the cytotoxic T cell. So it turns interferon gamma, polarize the immune system into M1 Th1. It starts with M1, and then when you polarize the M1 starts secreting cytokines that polarize the T cells into Th1, and then Th1 will start secreting chemicals that will turn the naive CD8 into cytotoxic T cells, and the cytotoxic T cells will grab the tumor and destroy it. You got my point?
Okay, now if cancer patient has a low lymphocyte count, a total white cell count is completely normal. But if they have a low lymphocyte count, then how are you going? Does that reflect the patient has the low lymphocyte count in the tumor, number one? And if it is so, then how do you handle? And on their mapping, they have a low CD4 and high, comparatively high CD8, but still CD4, CD8 count is high.
I will give thymosin alpha still, because it will polarize the immune system to Th1 and it will activate the whole immune cells in general, but it will lean more to CD8. Do you want to give thymosin beta? No, because thymosin alpha, it does help to increase the production of the lymphocytes in general, but more to CD8. So it does increase the CD4 and CD8, but more to CD8. You got my point? So I'll continue giving interferon gamma and thymosin alpha for those patients, because thymosin alpha will increase the lymphocytes in general, which is the naive T cells. Those naive T cells eventually will polarize more into Th1. Well, those naive so you have to know that Th1 it is CD4. The cytotoxic T cell is CD8. So the thymosin alpha increase the naive T cells, and that means it will increase the CD4 and the CD8, but more into CD8. You got my point? I'll continue giving thymosin alpha, and I'll give interferon gamma. I don't know if you want to give colony stimulating factor, the granulocyte, monocyte, colony stimulating, but it's not FDA approved, as you saw there. And the problem with that may
Which one is that? Which one is that?
The MG colony stimulating factor, granulocyte, monocyte, colony stimulating factor, the GM CSF. They're giving it sometimes to those patients to increase the white blood cells in general. You remember those factors that they injected to the body would increase the production of white blood cells?
Like Nupogen, right?
Right. So that's it. That's the granulocyte,
Right. Colony stimulating factor, right?
Right. So, but it's not FDA approved, and there's a problem with it because you may be releasing stem cells from the bone marrow that will differentiate in the tumor. So you may increase the burden of the tumor. So that's the problem. That's the reason why FDA did not approve it. But although some doctors are giving it to patients with cancer when they have low white blood cells, that's the only way they can. But for me, I will do interferon gamma, thymosin alpha. I will possibly patients has too much of interleukin 6, and if they do, then they have too much of neutrophil, and that will exhaust the immune system. And the white blood cells will be moving to that direction. So
you give patient ivermectin, what would you give?
I will give low dose naltrexone. If you want to give ivermectin, that's fine. I give methylam blue. Anything that Th17. Anti-fungal drugs, they are very effective inhibitor of Th17. So when you have fungal infection, those antifungal drugs by nature, they kill the fungus, but also they decrease the Th17 interleukin 6, which is part of the decrease the inflammation and kill the bug. So that's what you need, right? When you have rosacea, you have the mites, and then you have too much overactive Th17. So that's ivermectin when they used it, which is very effective drug comparing to steroids. It kills the bite, but also it decreases the inflammation, the Th17 inflammation. And everybody here needs to know that there is 3 kinds of inflammation. There is Th1 inflammation, there is Th17 inflammation, and there is Th2 inflammation, which is the allergies. And then Th17 inflammation, which gives you neutrophils, and then the Th1 inflammation, which gives you the cytotoxic T cells. And most of the diseases, you have a combination. Like in rheumatoid arthritis, there's Th17 and Th1, both of them. And allergies, you will see Th2 and Th17 are active. But some diseases, they have more Th17 than Th1 or Th2. Like ulcerative colitis, I see it's more of Th17 than it's Th2 inflammation. While Crohn's disease, it's both. It's really Th1, Th17. And so when you manage it, you need to block both polarization. It's a combination most of the time. But Th17 blockage, which is actually so from the lecture of Dr. Bill yesterday, he's using naltrexone. He's treating all the diseases, almost all chronic disease across the board. That indicates that Th17 overactivity, it's the pathophysiology of all the chronic disease up there. Do you agree with me, Dr. Bill?
Actually, I do, yes.
Okay.
So what about then the Dupuytren's contracture, where there is a overactive production of a collagenase and formation of the tissue? So that you would consider as a autoimmune process?
Well, part of it, because you know that diabetic, they do have too much of reactive Th17 and interleukin 6. Do you know interleukin 6 stimulate fibrosis? That's when the interleukin 6 too much of it can lead to fibrosis. That's the reason that explains why the patient with post-COVID-19, they have lung fibrosis. It's because of interleukin 6. So I think mediated by interleukin 6. So if you give something that inhibits interleukin 6 and Th17, it could be part of the management of the Dupuytren contraction.
So this patient has a Hashimoto's thyroiditis, hypothyroidism, and Dupuytren's contracture. So Hashimoto's thyroiditis, I have corrected it by the LDI for the Hashimoto's thyroiditis. However, and I have given her the low-dose naltrexone too, but I have not made a dent in her Dupuytren's contracture. So I was just wondering that how to, I mean, yes, if I had a collagenase, I can probably inject, but it's not available to the physician like us, except the hand surgeons. So I don't know.
Maybe topical naltrexone, or injecting naltrexone, maybe it will work. But I will have, Dr. Mike Beamer has a very good formula for that. He combines things together. He's like a wizard.
Right, no, I talked to Mike.
And what he
And,
said,
he said that collagenase is different. It's not fibrosis.
right,
It's a different animal. So
right. So he doesn't have a topical cream for
no,
it?
nothing local will not work.
Well, steroids, they're what they do, mainstream.
Right.
They do steroids, okay? They
That's
inject
right,
steroids
right.
into the pituitary, which will help to suppress the immune system, including the Th17. But I would recommend and try it. Just do topical naltrexone with shock waves and see what will happen, and possibly giving some injection of steroids if that doesn't work. So you go step by step if you want.
Yeah, I told her that if it doesn't get better, then that's what we will do.
Right, that's the only thing I think it will work. I mean, yes, steroids is the last thing you resort to do, but if you can do things without using steroids, that's better. So that's how I see it. I don't know. What do you think, Dr. Bill? Are you there? Anybody there? Any questions?
I think you covered it all.
Okay.
At least
Anybody has
part one.
questions? We will cover there's second part. Maybe we'll cover during the conference, and the conference I'll be very fast. I'm not going to be slow.
Well, we have you scheduled for 2 weeks from today.
Okay, so that's
The
mean I'm
second
just
part.
trying to
Next
make the
week-
doctors eager to, so the second part, we're gonna do the second part in the conference, or you want me here?
Well, the conference is starting from scratch, so they're going to have to, you're going to have to.
Well, that's up to you. I'm just trying to tell the people here, the second
Right.
part's gonna be very interesting. So I would like you to attend it, whether it's gonna be in a conference or.
Well, if we already have this, then well, if everybody's coming to the conference, at least online, we can do it that way.
Okay, whatever you like.
Okay.
I'm open.
All right. Next week, just for your information, and please spread the word, we have Jacob Teitelbaum will be here. And as you know, he is the father of chronic fatigue syndrome. He'll also be speaking virtually at our conference on Sunday, but he'll be here next Tuesday night, same time, same station. Those of you who are interested, if you go to AOSRD, I'm going to put it in the chat again, .org/event. That will take you to our website for the conference. We're 2 weeks away, and we have an all-star lineup, including Kent Crowley is going to be giving us a lunchtime talk on CBT and his company Troche. David Kahn is going to be there, I think, right, David? And we have College Pharmacy coming also. And, if you've seen the lineup of speakers, A4M can't do a better job. We have really high quality speakers coming, and please support us in one way or another. We would love to have you there. But if you can't make it online, and there is discounts for that, AOSRD.org/event, and it'll take you to our website. And the registration page is there. The whole lineup is there, and any other information you might need. Anybody have any questions about anything concerning that? You can get me either at, I'm going to put my email here, drbill9@gmail.com, or my cell is 570-881-6821. Okay. Like I said, we would love to have a really big crowd. Saturday night, Dr. Peter McCullough, I'm sure everyone here knows that name, will be here. He'll give us a lecture. He'll be the last speaker on Saturday night. And then there's a reception for him out on the patio at the Flamingo Hotel after that. So Sunday, we have Felice Gersh, who she's spoken to this group a couple of times, and she's a prominent speaker for A4M. And just as coincidence would have it, yesterday, I don't know, any of you get the Pure Encapsulations catalog. It's a really, I don't think anybody would even print this stuff anymore. It came in the mail. It's a couple of 100 pages. I flipped open one page and there she was. There was some formula that she had formulated for menopausal women. And there was her picture, the same one that we used on our advertisements, by the way. So she's there. Kathleen O'Neill Smith, you've heard her at her immunity talks. We have Gretchen Marsh coming. She's our local infertility specialist. We have Joseph Lillo, who is a lipidologist. Dr. Anwar, as far as I know, is still coming. He's coming all the way from Pakistan. He is an acupuncturist and a laser acupuncturist. Dr. Spear, of course, is our patriarch. He'll be there. Dan Stock, we've heard him. He got himself in the COVID kerfuffle about a year ago, and he spoke to us for about 2 hours without looking at a piece of paper or a slide. If you'll remember his talk, which was amazing. If you need state credits, pain management, David Leskovitz is going to be doing that again. Ethics, we have Dr. Cruz coming again, and also Dr. Stock also qualifies for medical ethics and suicide prevention. So those are all the Western state requirements, and they will all be satisfied at our conference also. So Dr. Crowley, you have anything you want to add?
No data for it?
No, Dr. Bill.
Okay.
Just looking forward to this awesome event that you have with so much CME.
Yeah. Okay. Oh, by the way, another thing, we are now up to we're at 26 CMEs, not 24. That just happened last night. And I'm trying to squeeze one more in, but I'm not sure if I can. So, but we're up to 26 CMEs, AMA and AOA. So, we qualify for both. So that's kind of a feather in our cap also. So anybody else have any other questions, comments? We have, some new folks on, as we always do. Dr. Peskin, who'll be speaking to us at the end of March about his work. And anybody have any topics that you'd like to bring up, please let me know. We're always welcome to newcomers. So we got a couple of great talks there, Dr. Halasa, very stimulating, and the usual attaboys. So we can't thank you enough, for being the impetus for this group and for your own, and for all the work that you do. We're looking forward to seeing you at our, in Vegas in 2 weeks. And please spread the word. Dr. Patel will be there. We'll be online talking also about chronic fatigue syndrome. Anybody else here that I left out? Dr. Burgess, Joel Peterson. They do a combination of suicide prevention. I hope I didn't leave anybody else out. That's about it. There's a little kerfuffle with the hotel about registration. So if you tried to register at the hotel and they told you it was sold out, let me know. We'll
playing for long sucks. Okay.
Yeah, and if they gave you a higher price than what was originally quoted, also let me know. Just send me a message because we're having a little issue with them on that.
So how I can call them? I just call them and tell them this is the group, and if they did not do it, so what I will do, I'll call you.
Well, you need to let me know, and we'll get our we have a hotel coordinator working for us. We'll get that together. I think Dr.
Because I'm going to book it tonight or tomorrow.
Yeah, I think Dr. Cruz went next door to Harris and they gave her the same price that the hotel gave us, but they're playing some games there. So let me know if they tell you it's sold out, let me know. Okay.
Okay, I'll call them and find out.
All right. Okay.
All right.
Anything else? Going once, going twice, same time next week, Jacob Teitelbaum will be here. You know, everybody, you should all know that name. Okay, I thank you so much. I know it's getting late. We'll see you again next week, same time, same station.
Have a good evening, guys.
Okay, have a good
Good
evening.
night, everybody.
Thank